Welcome to your lecture on the cardiovascular system. There's some learning objectives here. Make sure you're able to define what each one of these are. So if we look at the anatomy and physiology of the heart, it consists of the heart, arteries, capillaries, veins, pulmonary circulation, and systemic circulation. And we look here, you have some diagrams of the heart in cross-sectional views, so you can see each one. The heart is located in the chest, and it sits at an angle. You have the atria, you have ventricles, and you have layers. You have the endocardium, myocardium, and epicardium, and it's where the blood is transported throughout the body, and one of the stops is the lungs for gas exchange. And you should be able to identify all of this, if anything, just from your anatomy physiology class. So at the top we have the aorta coming across, and we have your pulmonary artery, your left atrium here, your pulmonary veins in the back, your bicuspid valve. You have your aortic semilunar valve here, your pulmonary semilunar valve, your left ventricle, your papillary muscles, interventricular septum, and you have the myocardium with the endocardium. And coming around, you have your inferior vena cava. I want you guys to know. I want you to know. Yep, your tricuspid and pulmonary veins over here. Here's your right atrium. We have your pulmonary trunk coming up off the right ventricle, going to your pulmonary arteries. And then you have your right pulmonary artery, and they're showing there, that's your superior vena cava, but back here. Here's just another view of it. So you have your aorta coming out over your left ventricle, and you have your left atrium, and your pulmonary valve with your mitral valve, left ventricle. Blood flows through here, so it comes through the superior inferior vena cava into the right atrium, into the right ventricle, through your pulmonary valve to your pulmonary trunk, and out your pulmonary arteries, comes back your pulmonary veins, deoxygenate. Its veins are normally deoxygenated, but this is reversed. So your pulmonary arteries will be deoxygenated and your pulmonary veins will be oxygenated. And then it comes into your right, left atrium to your left ventricle and out your aortic valve to your aorta and circulates through your body. So the physiology of the cardiovascular system. So the function of the cardiovascular system is supply and maintain adequate supply of blood to all the tissues of the body. This is accomplished by arrhythmic contractions of the heart, and the heart rate is controlled by the autonomic nervous system. So if we look here, cardiac cycle, you can see a strip here of a cardiac rhythm. So systole is the contracting phase, diastole is the relaxation phase, and the SA node controls and stimulates the heart for the mechanical contraction. So if we look, we have the P and Q, R, S, and T. So this is firing of the heart to contract. It contracts here, and then it goes into a resting phase. Okay, circulatory vessels. So you have arteries. They carry blood away from the heart. It's oxygenated. There's three layers, the outer, middle, and internal, the tubular structure. So on MRI and in angio, CT, anything where you can see actually the vessels, you will see a lumen on all arteries, and that's how you know it's an artery. The veins don't have that. The arteries are higher pressure, so they require a lumen on the inside. So it's the intima or the lumen that is different from the veins. So the veins carry blood back to the heart, and the capillaries are microscopic vessels that connect the arteries and the veins. And here's a picture of them. So you can see the artery, and then you have your capillaries, and it comes out the veins. So when we're doing radiography, we are doing certain parameters to ensure that we have a consistent heart size. If the heart is enlarged, it's called cardiomegaly, and that just means enlargement of the heart. We look at the great vessels also, and we look for vascular markings, and we also check for pneumothorax or pulmonary emphysema. And the bony thorax, we look at the and see if there's any scoliosis or pectus effectum where the sternum goes in. So with doing a chest radiograph, we do 1 million of them. Really important that you understand how to do them properly so that the patient doesn't get a misdiagnosis. It's also really important for MRI in the sense that we need to know where that pacemaker is and if the leads are properly placed. So if the technologist who shoots the chest x-ray has them in an oblique position or positioned incorrectly, it'll look like the leads are incorrectly placed. So a lot of technical factors in patient positioning that goes into it, and the radiologists read 1 million of these a day. So looking at a chest x-ray, we have the clavicles coming across here. This is the apices of the lungs, and that's usually where the implanted devices are. So we have defibrillators over here and pacemakers over here, and then you'll have leads that come down and are implanted within the heart muscle. So this is your cardiac silhouette here, and you have your aortic knob, aortic notch. This is your hilum on either side. You have your cardiophrenic angles here in the corners and your costophrenic angles down here. So the costophrenic angles, if there's any blunting, we're looking for any kind of effusion within the lungs, so fluid within the lungs. And you should see 10 ribs when we're looking at a chest x-ray. All right, so there's different imaging considerations for looking at the heart. There's echocardiography, which is heart anatomy, function, and vessel patency. There's M-mode echocardiography, which records the rate and motion and the amplitude of the moving objects. So it's a way to measure. So M stands for motion, but also measure. There's 2D echocardiography, which is real-time imaging, and transesophageal echocardiography. So they swallow a camera basically, and we take a look at the heart through the esophagus. And we have spectral Doppler, color Doppler, and stress echo. So stress echo, we will inject an isotope within them and have them run, take a look at the heart. So you can see the left atrium and left ventricle, and we're looking at the waves of the heart. This is within the carotid. They're looking at the pulse of the heart. You can see here it laid out in ultrasound. So nuclear medicine is used to diagnose coronary artery disease, congenital heart disease, and cardiomyopathy. So myocardial perfusion is widely used procedure. It's gated cardiac blood pool scans also. It's used to evaluate the ventricles, and positron emission tomography we'll use also. So when we look at nuclear medicine, it's a bunch of dots. So it's a radioisotope giving off its radiation, and it's picked up by a camera. So you can see there's a filling defect, looks like right here. Okay, so we have CT. Within CT, we have special software for cardiac scoring. There's also electron beam CT. It acquires the image differently. It uses electron beam instead of photons. It's supposed to be great for the heart. Actually, CT, the new 64 plus scanners, the 64, 256, 128s, are, I think, 10 times better than electron beam ever could be. They're still working on it and advancing it. So there's multi-detector spiral CT and CTAs. So just like MRAs, they're CTAs. And you can see here we have some ballooning, and you can see down here. So CT shows us well. MRI. So recently gained in popularity for cardiac studies, uses a cine loop, and it may be ECG gated. The scanners are getting really smart with the software where they can actually scan between the beats, which is great, so there's less motion. We can also do MRAs. So it's typical that when we scan a heart that we will give contrast and watch the uptake. So we'll do arterial and venous, so uptake and washout. So looking here, here's MRI of the heart. You can see the left ventricle right here, right ventricle here. Here's your atrium. And looking here, so this is axial plane. This is our coronal plane. And we have our atrium, right atrium, and here's our left ventricle and coming out the aorta. So good view of it. This is an MRA of the carotids before we manipulate the image and cut out all the unnecessaries. So we'll take this, we'll spin it, we'll cut it out, we'll spin it, we'll cut it. So it's just the coronary carotid arteries. I'm sure you guys have seen that already. So angiography, so we can send them to the angio suite, and it's the most commonly performed procedure for cardiovascular disease, and we can do diagnostic where we can just check and see what's going on with the patient, or we can actually do therapeutic where we treat the patient at the same time. So they use PTCA, percutaneous transluminal coronary angioplasty. So we'll put stents in, we'll break up clots, we'll remove clots, and just really cool stuff that we're doing within the IR suite. IR is interventional radiology. So here we put balloons in, we can open up vessels that were closed. This patient had heart surgery prior, so you can see the surgical clips and the sternal wires. So it's a dead giveaway. So they're measuring to see the size of the balloon, the size of the stenosis, so that they can treat the patient. All right, congenital and hereditary diseases. So fetal circulatory system, so there's the foramen ovale ductus arteriosus. So the incident of congenital cardiovascular anomalies, so they're actually pretty common. You'll read about it in your book. So etiology, so there's a lot of genetic disorders or chromosomal issues. Also environmental factors can cause this. And we usually pick it up by a heart murmur. So there's left to right shunts. There's terology of Ferlat, so I've heard it pronounced 10 different ways. So however you want to say it is fine with me. So, and corrucation of the aorta. So with your atrial septal defects, so ASD, it's a hole in the septum between the atria. So they are the most common, and pulmonary blood is increased, blood flow is increased, and the right ventricle is typically enlarged. So the blood from the left ventricle is crossing, or the left atrium is crossing into the right atrium. So you have a mixture of deoxygenated with oxygenated. So they permit mixing of the blood in the systemic and pulmonary circulations. Lungs become overloaded with blood. This is because the blood is preferentially shunted from the high pressure to the relatively low pressure of the pulmonary circulation. So the defect size and pressure differences control the magnitude of the shunt. So here's a picture of it, so you can see the hole where arterial and venous blood is mixing. So on a chest radiograph, this is what we're looking for right here. Here's your knob, which is really small, and you can see this predominance in the hilum right there. So, bummer. All right, so ventricular septal defect, which is VSD. It's a hole in the septum between the ventricles. It's more serious than the atrium because the pressure is greater in the ventricles than the atria. Shows left-sided heart enlargement, the heart murmur if opening is small, breathing difficulties if the opening is large. Large opening must be surgically closed to prevent future problems. And you can see here where the opening is, where the oxygenated and deoxygenated are mixing. So the problem is your right-sided heart is a lot weaker than your left-sided heart. And the muscle is a lot bigger on the left-sided heart because it's pumping the blood out through the aorta out to the whole body. So as this contracts, the oxygenated blood is going into the deoxygenated blood of the right ventricle and getting circulated back to the lungs and not going out to the body. And here's just the difference between the two. Here's the atrium, here's the ventricle, and what it looks like in anatomy. All right, patent arterial ductus, so PAD, exists when the atrial duct in a newborn fails to close after birth. It's common in premature infants and common in full-term births. Blood is shunted from the aorta to the pulmonary arteries and back to the lungs. Lungs become overloaded with blood, and heart is overworked to balance the oxygen supplies and demands. So chest images show enlarged left ventricle and left atrium and pulmonary vascular congestion. Patients with this must be closed off, and it does not heal well within a few weeks within birth. So if we look here, we can see there's multiple problems. So we're at 70%, 65%. So overall, the heart's not doing well. So the patent ductus arterius shunts blood into the pulmonary circuit, and then the foramen ovale shunts an equal amount out to the pulmonary circuit. The left atrium, the left ventricle, and the pulmonary veins, right atrium, right ventricle, and superior vena cava, all of these are affected. So you can see here we've just got kind of a mess. So here is a frontal chest radiograph, demonstrates cardiomegaly with enlargement of the left atrium. So here, left ventricle and pulmonary, central pulmonary arteries, there's diffuse increase in the pulmonary vascular markings. So all through here, all these are vascular markings, and they're very predominant. And we look here in another patient, and the aortogram shows patency of the ductus arteriosus here. Pretty cool. Cool shot. And you can see here we've got big problems. This is not normal, nor is this. All right. All right. Teratology of Furlat, so is the most common cause of cyanotic congenital heart disease. So it consists of 4 tetra abnormalities. So high ventricular septal defect, pulmonary stenosis, overriding of the aortic orifice above the ventricular defect, and right ventricular hypertrophy. So all 4 of those tetra. Most common cause of blue babies causes it to be cyanosis. This is right to left shunts, others are left to right. So not enough blood goes to the lungs to receive the oxygen, so the heart pumps harder. Temporary repair until the child's old enough for complete repair. The classic sign is a wooden shoe. So here's a good example. You have pulmonary stenosis right here. You have thickened right ventricle wall, which is not normal here. You have ventricular septal defect right here, and you have the aorta overrides the septal defect. So just a mess. Here's a plain chest radiograph, so the shoe. So they say this is supposed to look like a shoe. All right, so corrucation of the aorta. So it's narrowing of the aorta, causing a left ventricular enlargement. There are 2 types. There's adult and juvenile. The adult has hypertension, dilated aortic arch, and rib notching. And corrucation of the aorta is the narrowing or constriction of the aorta. It's most commonly occurs just above the branching of the blood vessels in the head and arms. The classic sign is normal blood pressure in the arms, but very low blood pressure in the legs. This is most frequently cause of hypertension in children. So you can see the aorta coming around, and then so the blood is coming off the subclave, so it's getting the upper extremities are getting full blood pressure and flow, and you can see that the lower limbs are not getting as much blood flow due to the stricture. And you can see an MRI right here, this notch, and you can see that we've got problems right there. All right, so this is the 4 defects. Sorry, the slide, it looks like it's out of order. I'm not sure why, but there you go. So valvular disease. There's ways that we can treat it that's invasive, non-invasive, and a lot of it is from rheumatoid fever. So refers to a valve that will not operate normally, usually caused by acute illness. The valve is either incompetent or insufficient. So here's from rheumatoid heart disease, mitral valve stenosis, insufficiency, aortic stenosis or insufficiency, and infective endocarditis. So rheumatic fever is an autoimmune disease that results from a reaction of the patient's antibodies against the antigen from the previous streptococcal infection. It damages heart valves, usually the mitral and aortic valves, and it damages valves. Damaged valves are either stenotic or insufficient. So stenotic means it doesn't open enough, so it's closed basically, and insufficient means it doesn't close completely. So here is a mitral valve stenosis. So mitral insufficiency is the most common cause by rheumatoid, and other causes can be rupture of the chordae, tendinae, I don't know, deficiency of the papillary muscles, Regurgitation of blood from the left atrium during ventricular stenosis causes overfilling and dilatation in this chamber. It leads to decrease in ventricular stroke volume and cardiac output. So you can see that we have big problems in this heart, and this heart's really large. All right, mitral valve stenosis is almost always a complication of rheumatic fever. It results from thickening of the valve by fibrous tissue, calcific deposits, or both. Blood flow is obstructed from leaving the left atrium and passing into the left ventricle during diastole. It causes increased pressure in the left atrium and enlargement of the chambers. So you can see here that we've got big problems. Aortic stenosis can be caused by rheumatic fever or congenital valvular deformity, especially the bicuspid, degenerative process of aging, the obstruction to the left ventricle outflow, and aortic stenosis increase the workload of the left ventricle. So you can see here coming around and down. You can see the three markings right there. Calcified. So aortic insufficiency. So it can be caused by rheumatic heart disease, syphilis, infective carditis, dissecting aneurysm, or Marfan syndrome. So common in Marfans. Reflux of blood from the aorta during diastole causes volume overloading in the left ventricle and dilatation of this chamber. So you can see right here the enlargement and the enlargement right here. That's not the heart. All right, so you can see the different valvular disease here, and normal valve. So the different valves. This is in your book, so you should be able to see that better. And you can see a person's had valve surgery, replacement surgery. Okay, so we're going to look at acquired valvular disease. So it can be coronary artery disease, congestive heart failure, pulmonary edema, hypertension, hypertensive heart disease, aneurysm, traumatic rupture of the aorta, dissecting aorta, atherosclerosis, and thrombotic or embolism. So coronary artery disease. So coronary artery disease is the narrowing of the lumen of one or more of the coronary arteries. The most common cause is atherosclerosis, which is the fatty deposit material on the inner lumen. It results in oxygen deprivation of the myocardium and ischemic heart disease. So it can be caused from hypertension, obesity, smoking, high cholesterol diet, and lack of exercise. And it's associated with angina, so pain in the chest, single most common cause of death in men and women in the United States. Scary. All right, so you can see here, this is a coronary study. So they're in interventional radiology, and you can see they've injected contrast into the heart, and you can see that there's no contrast right there. So we've got a stricture right there that they need to open up because there's ischemia happening to this heart. It's not getting its full blood flow, which causes chest pain. All right, so this is in cath lab again, and then here we've done a CTA of the heart. So myocardial infarction. So we all know what that means. So the heart muscle is not getting blood supply. So it's usually an acute thrombus of the coronary artery, sudden crushing pain that can go down the arm or up the neck, and you need medical intervention immediately. So 20 to 25% of the patients die before they get to the hospital. Yikes. If you get help within 30 minutes, your survival rate goes to like 80%, 85%. So you need to get to the hospital right away. All right, congestive heart failure. So you'll see a lot on the orders that says CHF. That's what it is. Congestive heart failure refers to the inability of the heart to propel blood at a rate and volume sufficient to provide an adequate supply to the tissues. And it can be caused by a heart abnormality, hypertension, any obstructive process that normally increases the peripheral resistance of blood flow can cause it. So you can see here, this is your cardiac silhouette. You can see how big this heart is. So it's in failure. And the fluid backs up because it can't pump It's not strong enough to pump the blood out into the body, so it backs up into the lungs. And you can see the right-sided heart failure, how large it is on the right side. The left side is enlarged also, but the right side's enlarged. And you'll typically see swelling of the right ankle, not ankles, ankle. All right, pulmonary edema is an abnormal accumulation of fluid in the extravascular pulmonary tissues. Most common cause is elevation of the pulmonary venous pressure. It's usually due to left-sided heart failure. It may also be caused by pulmonary venous obstruction or lymphatic blockade. Other causes: uremia, narcotic overdose, exposure to noxious fumes. Excessive oxygen can cause this, high altitudes, fat embolism, adult respiratory distress, and various neurological abnormalities. So here's the chest. These lungs should be black, not white. It's got a perihilar haze, that's what they call that. And you can see the butterfly pattern here, so it looks like a butterfly here. So there you go. That's your pulmonary edema. Hypertension is also called high blood pressure. It is a leading cause of strokes and CHF. Blood pressure is a function of cardiac output, the amount of blood pumped per minute by the heart, and the total peripheral resistance, which affects the condition of the walls of the blood vessels throughout the body. And a lot of the hypertension can be from kidneys. So if we have uncontrolled hypertension, when I say uncontrolled, means we're giving them meds and they're not responding to the meds, they still have hypertension. We'll do an MRA or a CTA of the renal arteries, and we'll look for stenosis. So you can see this left side's open, no problems, and you can see the right side has a blockage right here. So this patient needs to be treated in order to get their blood pressure under control. A lot of times we'll balloon it and stent it to ensure that it stays open. And it's amazing, their blood pressure drops immediately. Kind of cool. So hypertensive heart disease, long-standing high blood pressure causes narrowing of the systemic blood vessels and an increased resistance to blood flow. So the left ventricle is forced to assume an increased workload, which initially causes hypertrophy, so double thickness of a normal wall. So we look here, hypertensive heart disease, lateral projection chest shows predominant left ventricles. So this left ventricle was really sticking out there. So not normal. Normally it'll come down straight. So this one has got a big hump in it, like a big butt, looks like to me. And you can see it right here. See how large the right side looks normal in size, where the left side's really sticking out there. Atherosclerotic heart disease, characterized by thickening, hardening, and loss of elasticity of the atrial wall, also known as cardiovascular disease. Coronary artery bypass grafting is done when disease affects the heart vessels, and hypertension accelerates the plaque. So continual plaque builds up and results in myocardial infarction, heart attack, not infection. Atherosclerosis, so it's fatty deposits in the intima. It produces progressively narrowing and often complete occlusion of the large to medium-sized arteries. So major causes of disease. So we can see here the filling of the lumen. So there's fatty deposits here. That's not narrowed too much. It's still fine. Where here you can see it's built up and it's really occluded that artery. And we can see here we've got a problem. Looks like the popliteal, and we're not getting blood flow through there. So almost complete here. Looks complete here. It's got some peripherals feeding for it, which is good, but still very painful for the patient. All right, so lateral views of the chest show marked enlargement of the left ventricle. There's also tortuosity of the aorta and bilateral streaks of fibrosis. So here you can see the aorta just doesn't look normal, not normal. Infective endocarditis, so refers to the development of nodules or vegetations on the heart valves caused by deposits of bacteria or fungi. They are larger than rheumatic fever vegetations. Yeesh. Vegetations of infective endocarditis are filled with bacteria. They tend to break apart easily and form septic emboli. So infective endocarditis is demonstrated by echocardiography and radiology of little use since cardiac silhouette is often unchanged. So these patients, they look normal, but they have these septic emboli that keep happening. Very sick. Pericardial effusion is the accumulation of fluid in the pericardial space surrounding the heart. It can be from bacteria, viruses, neoplastic involvement, idiopathic pericardial effusion, and its rapid accumulation interferes with cardiac function because of an increased pericardial pressure. So the heart is getting squished by the fluid. I've actually seen cancer in the pleural space of the heart. It was crazy. So you can see how enlarged this heart is. That's not good. And you can see here is your pericardial sac, and within the pericardium you have fluid. This is the heart right here being compressed by the fluid. So the sac will only allow it to stretch so much before it starts to compress the heart. So you can see here. So I've seen cancer in here, and it's like, oh my gosh, what do you do with that? So right here with the arrow, you can see that someone's put a drainage tube in there so that the heart can properly pump and get blood to the body. So we did have a kid hit with a baseball right in the chest. Took a line drive to the chest, and he had a pericardial effusion. The trauma surgeon, he went to a trauma hospital, and the trauma surgeon was in on another case that was a serious case, couldn't come down. And I think he was 14, died on the table down in the trauma wing. It was the saddest thing ever. So I'm like, take a needle and just stick it in there. So you can see here, we've got fluid on the MRI around the heart where there should not be fluid. So that is an effusion. And you can see the white right there. So pericardial effusion around the heart. All right, degenerative disease. So PTA is the most common modality to diagnose atherosclerosis. CTA is increasing in popularity. The problem is we need to do hard plaque. We can see it shows up as calcium, but soft plaque does not show up until we give contrast, and we'll see an irregularness to the lumen. So it's important that if we're doing CT for coronary score, we do without and with. So Doppler sonography, MRI, and echocardiography visualize blood flows without contrast, which is really nice. We can't do that in CT. So aneurysms is an outpouching of the vessel wall. There's a lot of reasons that we get them. Calcifications. There's different types. There's secular, fusiform, and dissecting. So the secular is usually cerebral artery, and the fusiform is distal abdominal aorta, typically. So you can see the different types here. So fusiform, and we have dissecting, which is a weakening in the wall with the lumen with a tear, and this is just ballooning. And then a false is where it's bleeded out and clotted. So we have a complete tear through all the lumen, and it's leaking out and has caught and clotted. So looking here, we have abdominal aneurysm. This is a pretty small one. It's not real big. And here, in MRI, you can see it. And here, yikes. So in the extremities, we can get them in the popliteal. And let's see. Oh, look at this abdominal. So you can see the lumen, and then you can see where the blood is leaked out, and crazy. So here's your lumen, and here's where it's leaking out on either side. All right, and yeah, here, calcification in the wall, the aneurysm of the lower abdominal aorta, both common iliac arteries, the black arrows. These are the common iliacs. We have ballooning there too. These patients, they get stents put in, a sheath that's pretty cool. You can see here, and we have a clot within the lumen on your MR. And we had posterior Yeah, so they had a stent placed and then a stent placed down. And a lot of times they'll put the stent just below the renal arteries. And if not, they'll put a second one in the renal artery to ensure it stays open and the stent doesn't cover it, the grafting. All right, traumatic aortic rupture. So is potentially fatal complication of a closed chest trauma. So it can be rapid deceleration, blast, or a compression injury. Blast injuries from like bombs can cause this. And people that die in car accidents, a lot of it is from the rapid deceleration. So that'll cause the aorta to rupture. It can't handle that kind of force. Usually the aortic tear occurs distal to the subclavian artery at the site of the ductus arteriosus. So here you can see it's ruptured and leaking. All this is fluid. Not good. So a dissection is potentially life-threatening condition in which the disruption of the intima or inner layer of the blood permits to enter the wall of the aorta and separate its layers. It creates a true or false lumen within the aorta, and the false lumen may be an aneurysm as a result of high pressure in the systemic vascular system. So the most common is patient with arterial hypertension. Other causes is trauma, congenital defects such as Marfan's. So here you can see, oh my gosh, this one makes my armpit sweat. That is huge. You can see we've got huge artery and we have a dissection in the lumen, and same here. So coming down the thoracic aorta, we have a dissection also. Ooh-wee, that one would scare me. So here also. So venous disease, so there's deep venous thrombosis and varicose veins. So we'll look at the incidence is usually from phlebitis, thrombus, or thrombophlebitis. Oops. A thrombus is an intravascular clot. It can be from sitting around or flying. Endothelium injury or inflammation, blood changes, so changes in clot mechanisms, increase in red blood cells. Embolism, part or all of a thrombus that becomes detached from the vessel wall and enters the bloodstream, and it lodges in other vessels, causing ischemia or occlusion of that vessel. So the types of embolism can be fat due to trauma, so fracture. So a lot of people with fractures will get fat emboli. Septic from infections or air, so air bubbles introduced via trauma, surgery, or injection. Deep vein thrombosis primarily involves the lower extremity as a major source of potentially fatal pulmonary embolism. So it can be trauma, bacteria, prolonged bed rest, or oral contraceptives. I've actually seen that in the brain, where you had a clot go up into the brain, into the venous system of the brain from someone flying who was on oral contraceptives. It was a really cool case. So DVTs may be the earliest symptom of an unsuspected malignancy of the pancreas, lungs, or GI system. So if they're getting a DVT, we need to look and see why they got it. So here on this first one, look how big this DVT is. Oh my gosh, so that clot's ready to go. And then looking here, you can see the little snake, the little bloop, 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 filling defect there. Yikes. And going out to the renals, we have a clot that completely blocked it off. So we've got to get blood flowing again, or we're going to have a lot of problems. So we have a little filter in here, IVC filter. We used to call them greenfield filters. So a filter, and so what happens is the clot comes up, and it gets broken up in this filter, so that if it does go into the lungs, it may not be as threatening. And you can see here, oh. All right. Varicose veins are dilated, elongated, tortuous vessels that most commonly involve the superficial veins of the legs just under the skin. And you can see here, we've got lots of them here, and even more here. Look at all those. So they'll go in and they'll remove these because it can be painful, and patients can have swelling of the legs because of this. Very painful. All right, transposition of the great vessels. So it's not that common. Really important that you put your patient in the right way, that you mark your studies. And as you can see here, It's supposed to be coming off the other way. There's no markers on this kid. They're young. I can tell by looking at the bony structures, but the aorta is supposed to come off this way, to the left, not to the right. So everything's just flipped. So not a big deal. Here's a review of the really important ones. This concludes your cardiovascular system pathologies.